I was wondering for a second whether it's actually need to talk, because Mark already said we're doing anything we can anyway, so why talk about monitoring? But let me see whether I can give you some new aspects. I want to be just quickly reviewing the actual numbers right now. This is actually something that you're probably aware of, but many people mistakenly believe that in endovascular treatment the numbers for thoracoabdominals are lower when it comes to paraplegia. Is actually not true. This is the current literature. Don't want to bore you with this, but even the most experienced centers in the world did not manage to get the paraplegia rates below 5–6%. And you see that from Roy Greenberg, it's not historically yet, but it's 6 years old data, it's still 20%. Why is that? Because we all rely on a very old understanding of spinal cord perfusion. This is the thesis of Adamkiewicz from 1881, published in Krakow. And these are those beautiful drawings that I got from Dr. Grieve. And all of us, I believe, learned in medical school that there's one artery that supplies the spinal cord. And this is a paradigm that's probably wrong. At least it's not applicable for our purposes. This is a paper, my first paper that I wrote with Dr. Grieve, and all of those bars you see on this image represent one patient that had complete sacrifice of all segmental arteries on all the levels that these bars cover. The red area is where the artery of Adamkiewicz is supposed to rise from the aorta. So theoretically, statistically, there should be 60–70% paraplegia rate if this paradigm was true. Fact was, it was only 2%. It's a mix, not all have two aneurysms here. So something must have been wrong with this theory. So we went to the lab, and interestingly, that's my belief why no one solved this issue so far, is that because there's totally different mechanisms behind it. In open surgery, we basically cross-clamp. In endovascular, we sacrifice segmentals. So unfortunately, it appears that both mechanisms have about the same incidence or cause the same incidence of ischemic spinal cord injury. That's why it hasn't been solved, I think for 60 years now. So I went to the lab and distinguished between these two mechanisms. First experiment was to mimic open thoracoabdominal repair. So we cross-clamped the aorta, and then we measured the flow to the spinal cord. And I want you to just focus on these two lines. When you place your cross-clamp, spinal cord perfusion goes down to 0 in this area. So the only measures you have, and this is what Mark already and Dr. Wu emphasized, is to keep the pressure up and keep your cross-clamp time low, keep it down, keep it short, and keep your temperature low. That is the only protective measures you have intraoperatively. So if you look on those images I brought here, this is the spinal cord capillary bed, 3D microscopic HD image, and this is actually what we're looking at in the spinal canal. And I believe most of you have seen these pictures. This is an acrylic resin cast of the collateral network around the spinal cord. So we basically loaded the heart-lung machine with acrylic resin and then perfused the pig, dissolved all the organic tissue. You see the aorta, the renals, and this really huge collateral network that surrounds the spinal cord. And you can see that there's lots of connections from both sides along the spine and collaterally. Very interestingly, it compares very favorably to the human anatomy. This is a picture taken from the Bodies exhibition. Don't want to know how this was actually created. And you see that there's a really not one artery going to the spinal cord, but it's a number. They are already, if you use different colors, you can see that there are already collaterals that's basically connect segments along the spinal cord. And you can see that in the spinal canal, there's something that we call the circle of Willis-like circuit, that are repetitive circuits within the spinal canal that can redistribute blood if one of the segmental arteries is sacrificed in the same area. Here another picture. I just want to give you some visual ideas. So when it comes to spinal cord monitoring, what is it actually that we want? We want it to be non-invasive. We want it to be in real time. Ideally, it should give us information on the perfusion. It should work intra and post-operatively, and it should be hopefully easy to use. SCPs have sort of disappeared over time because they do not offer all these aspects, and mostly only intraoperative MEPs. We have heard a lot of right now, and we have the same issue in Leipzig, that we don't have the neurophysiologists, so we just can't do it, and this is an economic issue also, so it's not used in Leipzig. I was desperately trying to find other measures to monitor the spinal cord. One way is to do direct spinal cord perfusion pressure measurements. I'm going to show you in a minute how that works. Laser Doppler only to be used experimentally because you have to stick a probe into the spinal cord. And then there's something that we came up with. It's based on near-infrared technology, and we named it Collateral Network Near-Infrared Monitoring. Has been used in the past, or attempted in the past, didn't work because light cannot penetrate bone. If you put your optoid in the middle of the spine, it just doesn't work because it doesn't reach the spinal cord. Also, the spinal cord tissue is so little that you're never going to get real information focusing on the spinal cord. So here comes the idea. A little slow here. If you know the oxygen in your collateral network, you know the oxygen in your spinal canal. That was just the hypothesis. So we placed those optodes on different levels, and then we did a pilot series already published. Seems to work quite favorably. It's just first in man and feasibility study. We haven't evaluated, so we need to go to the animal lab and do a proper validation of that method. Experimental setup just shown here. Basically what we did at Sinai also, place those optodes, place a laser Doppler flow probe which has been evaluated against microsphere measurements, gives you objective understanding of perfusion oxygenation to the spinal cord, and then you go ahead and do your procedure. We did that in a couple of animals. This is the setup in the I move this and can walk around a little bit. No, huh? In the animal lab. So very complicated. On the left side here you see the collateral network. On the right side the spinal cord. Direct measurement with laser Doppler flow. Open circuits is oxygenation, and the dark blue or black ones is the flow. You see when you place your clamp, flow and oxygenation go down, and very much the same in the collateral network and the spinal cord. There is a correlation between these two compartments. So first part of the hypothesis, the collateral network equals spinal cord oxygenation, has been shown here. There's some statistics to it. You see a very good correlation between the two compartments. And so the next step, so in other words, we can use the collateral network oxygenation as a surrogate marker or measurement for the spinal cord. So now it comes to the non-invasive collateral network near-infrared monitoring. Same experiment. Place your cross clamp, release it. This is again the flow in the lumbar collateral network. And here comes the lumbar spinal cord oxygenation measured by laser Doppler. So it's a very similar curve. It gives you a good idea of what's going on with your spinal cord when you place these optodes on your collateral network. Again, the statistics compares very favorably. So this is one new technology that we have introduced. We're now testing it in a larger number of patients. We don't know whether it works for stent grafting, but at least it gives you a similar warning sign in the OR that if it goes down, start using your distal perfusion or just raise the pressure. So next experiment was segmental artery occlusion. Same setup. This is a validated model. You see that we can mimic in this chronic large animal model paraplegia rates that we see in the clinic also. On the left side here, on the right side of the slide, you see the Tarlov score, a little bit modified. All the animals below the red line are paraplegic. And this is a system that we developed. Basically, we ran out of microspheres in the lab, and I had the idea to put a catheter in one of those segmental arteries and measure the pressure, see whether that video works. We then used that technology also in the OR. This is me putting one of those catheters in with Dr. Grieb on the thoracoabdominal. You see on this picture below how that works. So we sacrifice the artery and then put the catheter in, and it gives us information on the spinal cord perfusion pressure. I got into some weird mode here. Let's see. So can we jump to the next slide somehow? Does it on the monitor here? Doesn't do it. So the first patients that we used that technology, we got for the first time we got spinal cord perfusion pressure monitorings. Go this next slide. Yeah, now the next one. Go to the next one. Oh yeah, yeah, okay. So you see here, just want you to look on the left upper drawing here. You see one patient had very low spinal cord perfusion pressure recordings, but that was one of the first patients we didn't know what the normal values are. Unfortunately, that patient ended up paraplegic, and that is, you see the other spaghetti plots on the upper part there. These are the patients that ended up normal. With normal spinal cord function. So that technology also works, but it's very invasive. You have to have this catheter, you have to find a way to pull it out after the operation. It may bleed, so it hasn't really come to reality. We use it every now and then, but we don't use it all the time. This is this one patient that had very low measurements. But it is probably something that we can use. So this is a drawing that gives you an idea how we calculate spinal cord perfusion pressure. Collateral network pressure minus the cerebral fluid pressure, which is obviously easy to measure with your CSF catheter. You have to be aware that not only the CSF pressure, but also central venous pressure contributes to the pressure within the spinal canal, because the veins are directly connected and they are inside the spinal canal. So, but back to this experiment, we sacrifice the segmental arteries. You see here what happens. The spinal cord perfusion pressure goes down, measured with this catheter, and then 48 hours later, it starts recovering. And when I saw that for the first time in the animal lab, I thought there was something went wrong with my clips on the segmentals. They came off or something. In the autopsy, you saw they were all there, and we had 100% recovery after 5 days. That was reliable. We could do that with all animals. And we had, there must be a mechanism, in other words, that can regenerate spinal cord perfusion. And now we had to look in the microscopic images of that collateral network. Here's some electron microscopic pictures. Of course, as a cardiac surgeon, I have no idea what I'm looking at here, so I sent it to Max Planck Institute in Germany, and they said, what you see here is arteriogenesis. And they were totally excited and said, well, how did you create these pictures? And I said, well, I explained to them the setup, and then we said, okay, there's other changes. There's an enlargement of lower thoracic and lumbar collaterals. There's an enlargement of epidural arcades. And most interestingly, there's a complete change of the architecture of the small arteries in this collateral network. See on the left, this is a natural native state. And on the right side of this image, so here, you see what happens 5 days after occlusion of all segmental arteries. If you put that into scientific numbers, you see here that they are all in a random alignment, and after 5 days they start changing into a parallel architecture, which is most pronounced in the middle of the spinal cord, where the distal and the cranial inflow is furthest away. So the body tries to redirect blood to where it's needed in the middle of the spinal cord. So with this knowledge, the idea of the stage therapy was born. And we did the same experiment in 2 stages, and we actually got 100% recovery in all animals. That was the second time that we had experimental evidence that the mechanism behind this actually really exists, and that we can modify our procedure just by not taking all the segmentals intraoperatively, but do it in a staged fashion preoperatively. Problem, of course, you cannot offer your patient to cut him open twice. Here's the catheter again that measures the pressure. This is why the pigs don't get paraplegia anymore, because the pressure does not go down that far. Again, that's what I've shown you before. This is retrospective clinical data. So I went to a database at Sinai with 800 patients and tried to find those that, some of them that had accidentally a 2-stage procedure. You see this on the left side of the slide here. That was not intentionally staged. It was just a patient that came with a thoracic aneurysm and then with an abdominal aneurysm, and they were basically staged by accidents. And there was 0 paraplegia in that group as opposed to the incidents that we usually see. First clinical data that is actually also retrospective from Stéphane Hollande from Lille. He had compared 100 patients in the conventional way with a 14% spinal cord injury And then he started staging, and he reduced his paraplegia rate by almost 10 times. So we needed technology to prime the collateral network minimally invasively. These are some experiments also from Sinai with coil embolization. This was the idea. We go in with a catheter and occlude the segmental arteries. Same results, 0 paraplegia after complete coil embolization of all segmental arteries. Next idea was to name this procedure and find the right equipment for it to use it clinically. We named it minimally invasive segmental artery coil embolization. This is the first in man application we did together with the University Hospital in Hamburg, 2 high-risk patients. And they were doing fine, but it's just showing that the technology works in man. So now we have a stage preconditioning, which is clinically available. We can do that in 1 to 2 or even 3 sessions in the cath lab. It reduces our steel. You get a cleaner OR field, shorter OR times. And what I didn't even realize when we came up with that idea, it reduces the type 2 endoleakage. So it has a really, really profound impact economically. And you all know that the FDA was about to reduce the use of stent grafts because of that problem. So here's a short movie how we do that in Leipzig. So just a model of the arteries. You see the segmentals here in a minute. A little bit too small actually in this. This is a patient that had a chronic type B dissection. Pretty complicated case because some of the segmentals arose from the false lumen. So it's now routine that we place our optodes there, but just for scientific purposes because we collect data whether the technology also works for the Misaki procedure. Then this is how that baseline measurement monitors look like. And then you go in the left femoral access, 6 French, put your catheter in, do an angiogram, locate your segmental arteries. It looks pretty difficult. This is our pediatric cardiologist who's doing that for us because they are very experienced with coil occluding MAPCAS in children. You can also ask your interventional radiologists or angiologists, and you can even do it yourself because start though with simple cases. It's not that simple. Here's the coil applied to a segmental artery. They don't always occlude right away. Sometimes it takes a couple hours or days for them to really occlude. And now you see here different ways of pushing that coil in. Our pediatric cardiologist is a very cold-blooded guy. He just shoots them in with some saline. You see that here again, slow motion. And then sometimes you need a couple of coils to get the result you want. And the real-time collateral neos monitoring did not disappear so far, but we also evaluated in the experimental setup right now. And then you see here again, coil coming, and then in a second shoots up. This is one of those patients that had 1 session. We do not occlude more than 6 or 7 segmental arteries in one session so far, but we have no sufficient data yet, so we have to have a good safety margin. International echo on the Misaki technique that we have reached several important breakthroughs, and hopefully this is going to prove true in a big trial that we're starting right now. A couple words to the safety of Misaki. This is experiment data again. We haven't seen any histologic damage in the areas where we put those coils. Of course, that's of utmost importance. And at the end, I wanted to show you just a few words on delayed paraplegia. That is a very important problem. This is a slide that Joe Bavaria gave me, and he said, look, I have seen lots of patients that develop delayed paraplegia days or weeks after the procedure, and this is perfectly fine with the idea that the collateral network has not recovered properly at the time. The patient has some hemodynamic instability and then develops paraplegia. So this is a paper or a study that I did on that specific topic. Out of 800 thoracoabdominals with a very low paraplegia rate, not all type 2s though, I picked 10 cases with delayed onset paraplegia and 10 matched controls. All of those patients had intact MEP measurements at the end of the procedure. That was the major point in the study. You see here 10 patients on the left delayed onset paraplegia, and on the right, average number of segmental artery sacrifice was 9 in both groups. And I was very disappointed. There were no significant differences in all the post-operative measures that we did. There was no changes, no difference in arterial and mixed venous and oxygen saturation. There was no pressure differences and so on. That was what I had expected. I expected that I would see some differences in the mean aortic pressure post-operatively. I was very disappointed when I saw that there was absolutely no difference in both. That would mean it doesn't matter what pressure you put on. But then, when you think about it for a while, you realize these are all patients that have their individual blood pressure, so they are hypertensive patients. And if you then look into the mean arterial pressures that they had previously, as opposed to those that they had that were adjusted to on the ICU, you see that those that became paraplegic were adjusted on the ICU to only 80% of their individual pressures that they were used to, and that was probably key. So what we started now in Leipzig to look into what is the patient's regular blood pressure if he is a hypertensive patient. And we tried to go to make that the target arterial pressure on the ICU for the first couple of days. You can read many of those aspects in a recent position paper of the EACTS. Most of us are authors on this. And this is what I hope will solve many of the problems that we had in the past with this topic. It's a randomized controlled trial that I initiated. It's funded by the European Union with 6.3 million euros. And we will basically screen and choose type 2 aneurysms. They will be verified in Scandinavia, and then they will be randomized into conventional arms, so TVAR or open surgery, and then there will be a second experimental arm, where we do the Misaki technology, and then we'll look into the clinical outcome in a randomized controlled prospective trial, which started in January 2017, and we'll probably have the first patient in January 2018. These are the centers that will contribute in Europe, including Houston and Philadelphia. And we have also applied for extension of that trial in Germany. So if we get another funding by the German NIH equivalent, the German Research Foundation, will probably have 30 of the most high volume aortic centers in the world to contribute to that trial. Thank you very much.